Our next speaker is Dr. Jyotirmay Biswas, who will speak to us on the cytopathology and uveitis.
So, good evening. I have dreamt of this kind of a forum where the clinician and pathologist can interact in a long time. Today it's possible in the AIOC platform, may not be that many people, but we wish to grow and have that good clinician-pathologist interface. Today I'm going to talk on cytopathology in uveitis. Myself is an uveitis specialist as well as ophthalmic pathologist. So I'll show few cases and highlight the importance. This is an 8-year-old girl I've seen about 25 years back, persistent hypopia and uveitis, not responding to the topical and systemic steroid. What is your diagnosis? We did the anterior chamber tap and it showed basophilic cohesive cells with hyperchromatic nuclei and scanty cytoplasm suggestive of retinoblastoma. This is a diffuse infiltrating type of retinoblastoma which can infiltrate the anterior chamber and doesn't have any mass lesion in the back and can have an ultrasound show no calcification. This is a 7-year-old girl, acute lymphoblastic leukemia. Peripheral blood smear was normal. CSF was negative for malignant cells. He has a white hypopian with convex border and iris stroma was infiltrated with a whitish lesion. What could be? We did an anterior chamber tap and it showed lymphoblast and plenty of lymphoblasts clumped together, and it was an acute lymphoblastic leukemia and it's a recurrence of the lesions. CSF tap was negative. This is a 20-year-old man, and I can remember in dream also, hypopia and uveitis refracted to the topical and systemic steroid. After 1 week of waiting, we decided that I asked Dr. Badrinath what to do about this case. Hypopian is not responding. He said, why don't you do a tap? We don't do a tap for an acute anti-uveitis with hypopian, and we found that the patient is having a microfilaria. And this patient is a 14-year-old girl, history of fingernail injury, and this patient has granulomatous uveitis, and there's an engulfed lens matter was seen in the anterior chamber aspirate. This is 7 days post-cataract surgery, and you can see a exudative mass lesion in the anterior chamber. Somebody thought that there is a lens matter, but we did an anterior chamber aspirate and it showed fungal ball, KOH chalcophore stain. So pathologic study is required in infectious etiology, lens-induced uveitis, parasitic infestation, endophthalmitis, masculine syndrome, and required in selected cases only. Pathologic study is also important in many ways, like anterior chamber tap, iris biopsy, vitreous biopsy, retinochoroidal biopsy. Anterior chamber tap is quite easy procedure. OPD procedure, 27 to 30 gauge needle, 1cc tuberculin syringe, 0.1 to 0.5 ml of the fluid. Culture for infectious etiology should be done because it's the gold standard. So how do you approach? You take an intraocular fluid, do the direct smear or cytospin. A portion goes to the culture and a portion for PCR for molecular biology study. Cytospin preparation machine is 1000 RPM for 5 minutes, and you get a concentrated smears, and this is a case of adenocarcinoma. The patient had hypopia in the anterior chamber and later on found to have lung carcinoma. This culture is the gold standard, but it takes often long time and often it is negative. Often need to be combined with PCR nowadays with can culture. So real-time PCR, we depend on that one. Is a fluorescent molecule is used to monitor the PCR reaction. Fluorescent emitted by the fluorescent molecule manifolds as the PCR product accumulates with each cycle of amplification. And this is a real-time PCR machine, and this is a 48-year-old male, came to us with gradual progressive dimness of vision in both eyes since 15 days, history of fever 3 months back, fungal endophthalmitis showing multiple areas of retinal exudates with hemorrhage. What we did, we did a PCR for all the viruses and in the infectious organism like toxoplasma, etc. 9 copies of the chikungunya virus was found. As you know, there is no treatment for chikungunya, and we did the treatment with the steroids, and there is a complete resolution of inflammation. And this is just, I just have 2 minutes time. Multifocal serpiginous choroiditis, we did the PCR study, and aqueous aspirate was positive for Mycobacterium tuberculosis DNA. Real-time PCR showed multiple copies of the Mycobacterium tuberculosis DNA. Real-time and nested polymerase chain reaction in the diagnosis of multifocal serpiginous choroiditis. Iris biopsy is required in selected cases. This was a 10-year-old girl, no history of trauma, and had a mass lesion in the iris. We thought that this is a tumor, but when we aspirated that one, that showed aspirated material was KOH chalcophore showing fungus. Iris biopsy is needed is metastatic lesion of the iris and ciliary body, muscular syndrome, ruptured irises presenting as anterior uveitis, iris and ciliary body nodule, granulomatous uveitis. Vitreous biopsy is required in selected cases, suspected infectious etiology, not responding to the maximum anti-inflammatory treatment, fucoanapolytic uveitis, and most important, primary vitreoretinal lymphoma. This is a vitreous biopsy technique, and we take 3 probes and then take vitreous material, and multiple levels of the vitreous aspirate is taken. And you see a malignant lymphoma cells with necrotic background, which is quite important, and you should be very careful about examining the cytopathology and looking for the abnormal cells. And this may be accompanied by the normal inflammatory cells and lymphocytes. This is an 11-year-old boy. This is I switch gear, and I showed one case, 11-year-old boy with gradual decreased vision, floaters. And this patient had got lesions over that one with, say, subinternal limiting membrane lesion. What is your diagnosis? And this patient, a normal ESR, only thing is the serum ACE was elevated. SS-associated through macula showed the subinternal limiting membrane deposits. Is the raised ACE is enough for diagnosis of sarcoidosis? You know, sarcoid children is the ACE level is often high. We asked the opinion from the experts, and they said that can go ahead for the vitreous biopsy. And vitreous biopsy showed in this case cohesive blue cells, malignant retinoblastoma cells. So it was an atypical presentation of bilateral retinoblastoma with proteus and subinternal limiting membrane. Cytopathology and polymerase chain reaction of the vitreous fluid in tubercular intermediate uveitis. This is a case where I got a dense exudates in the vitreous. We took a vitreous biopsy which showed granuloma. Macrophages were seen, and the PCR suggestive of Mycobacterium tuberculosis DNA amplification was seen, and it was suggestive of tuberculosis. This is a 50-year-old man, and then had woolly strand of vitreous opacity. We did a vitrectomy, and then the optical vitrectomy showed concomitant positive vitreous amyloidosis. Fine needle aspiration biopsy, this is a 14-year-old girl, sudden dimness of vision for 1 week, and we did a fine needle aspiration biopsy. Few AFB was seen, but PCR showed MPV for FNAV was positive. And what happened to the patient? Dramatic improvement with ATT treatment, complete resolution of inflammation. In conclusion, cytopathology is required in selected cases, should be done after morphologic diagnosis and other investigation, must in a muscular syndrome, should be combined with PCR and culture in infectious disease, and should be correlated with clinical findings. I'd like to dedicate this talk in the memory of Dr. S.S. Prabdhbhushan, Dr. S.S. Badrinath, who has brought the modern ophthalmology, academic ophthalmology in this country, and I'd like to follow the life and legacy of this great man. Thank you very much.
Thank you very much, Dr. Biswas, for that excellent talk.